So today we take a look at another papillosquamous disorder. This is what we call lichen planus. Greetings to everyone. I'm Dr. Abraham from A&E Dermatology Specialist, and I'll be taking you through this condition. So we shall look at the current updates, the etiology, what has been updated in the current research, and then we see what is happening, what are the clinical variants that have been now reported and how they are classified, and the different treatment modalities that are being used to treat this condition. So a point to remember, lichen planus is one of the chronic conditions that are immune mediated, and it can affect the skin and mucous membranes in patients who acquire it. And it goes by a rule of 6. At least this one you should remember. Remember the 6 P's, and the first P being planar, which means flat. The second P being purple, which sometimes looks violaceous in the black skin. And then polygonal, you'll see lesions which have different shapes. And then most of the times patients can have a little itch, which we call pruritus, and then they present with papules and plaques because it is a papillosquamous disorder. And remember, I told you in one of the videos that every time you see papillosquamous disorder, it simply means that in this condition, the initial lesions that the patient will present with will either be a papule or a plaque that has a scale on top. So that's what constitutes the papillosquamous disorder, and that's what it means. Squamous means these are layers of skin, which is which will translate into a scale. So lichen planus has a prevalence of about 0.2%, 1% global, affecting both men and women without any racial discrimination. And we see that lichen planus is seen in the general population in about 2 to 5% of the population, wherever it is more, however, it's more common in women compared to men, which they say it is twice as common in women compared to men. And typically, the age of onset, the peak is between 30 to 60 years. However, other groups can be affected, and it can also occur in children, though very rarely. So we have the clinical forms, and we have what we call the typical form of lichen planus, and that's what we'll present with the classical picture that we know: the small flat-topped papules, which are usually polygonal, with sometimes having a erythematous base. And most of the times, on top of the papule, we see what we call the Wickham's striae, which is usually very vivid when you do a dermoscopy, and you'll see a reticulate whitish scale, which we call the Wickham's striae. So when you look at how the common sites that are affected, so commonly it loves to affect the extremities, especially the wrist joint around here, and then also around the ankles. And oftentimes it can also affect the dorsal aspect of the hand and feet, so this area here, and the lumbar region. And the less common sites, it can be generalized. It can also affect the entire body, and as well as the mucous membranes, including the genitalia, including the esophageal mucous membranes, including also the oral mucosa, the oropharynx, and sometimes they have also reported it to affect even the mucosa of the bladder, so, and the urethra as well. So those are the rare sites that it can affect, and the symptomatology will include severe pruritus, sometimes with visible scratches and secondary infections, and the prognosis is usually good because you know that the classical lichen planus will resolve in about 2 to 3 years unless otherwise. So someone will have the condition, but it has a good prognosis. So the oral involvement, most of the time, up to some literature says up to 70% of patients with actinious lichen planus may end up having also oral involvement. And predominantly, you will see reticular or erosive forms of oral involvement. And we know that in the oral involvement of lichen planus, there's also an increased risk of developing cancer. So as you can see in this picture here, you see that plaque there that has a whitish coating on top. So that is usually the Wickham's striae, and then this is a plaque of oral lichen planus. And if you are to look at the affected mucosa, as I had mentioned earlier, we can have external genitalia, the vagina, perianal area, urethra, conjunctivitis, the nose, the pharynx, as well as the esophagus and the urinary bladder. And it can occur in other comorbidities, including the autoimmune diseases of the liver, like and also other systemic conditions like systemic lupus erythematosus. It can also occur, or it has been also associated with other mental illnesses, including depression and anxiety. And it has a great impact on the quality of life of every patient because of the pain and itching and emotional stress and social complications that can manifest with this condition. So when you go to etiology, now this is the updated etiology of lichen planus, and it is now more similar actually than to the one of psoriasis, because all of them are in the papillosquamous category. So this one is also tending to have a similar pathogenesis. So lichen planus is thought now to have a contribution of these three different aspects. The first one are the environmental factors, where there's a thinking that lichen planus can be triggered by infections, including hepatitis C infection, hepatitis B infection, and some bacteria like the mycoplasma. There's also thinking that it can also be induced by trauma and stress as well. And then we've seen all this also in the pathogenesis of psoriasis. Then we have the genetic interplay, where there's a thought that all these environmental factors come into play in genetically predisposed individuals, which may have a defect in either their adaptive immune pathway or their innate immune pathway gene. So in this case, we have a genetic contribution. So the other arm has the immune factors or the immune dysregulation that usually occurs, and this usually involves the T cells, the keratinocytes, and the dendritic cells. So you'll see that all this pathogenesis that has been updated is more or less similar to the one of psoriasis, but a difference in the cell lines and the pathway, as we're going to see. So in lichen planus, when you are to assess the genetic predisposition, it was seen that in identical twins and up to 10% of the first degree relatives, they tend to develop the same condition. So also there's a thinking that we have familial forms of lichen planus that contribute to up to even 10% of the cases of lichen planus. So meaning that maybe the father had lichen planus, then the daughter or son ends up developing lichen planus, or the twins have lichen planus, the identical twins, meaning that there may be a genetic basis. And usually in the familial type or in the familial form of lichen planus, it usually has a very early onset compared to the rest of the forms, and it has frequent relapses, and most times it's the one that is resistant to treatment. So if you're treating lichen planus and you see that you're giving your conventional treatment and there's no major improvement, you may now need to think and assess to see whether it is a familial type of lichen planus. And the HLA, or the human leukocyte antigen association to lichen planus, include HLA, A3, HLA, AW19, B27. This is also seen in B7, also seen in psoriasis, B18, then CW8. And we can also get sporadic mutations like the HLA-DR1, HLA-DQ1, and then HLA-BW35. Then in all lichen planus, we have an association with HLA-B8, B51, BW57, and then BW61. So these are the associated leukocyte, human leukocyte antigens that have been linked to lichen planus. So these gene studies have been able to demonstrate that most of these abnormalities may play a role, or most of these genes may play a role in development of lichen planus. And then the other aspect is the polymorphism. Polymorphism, that's where you have one gene but presenting differently in different people. So for example, if you're looking at maybe like the cytochrome system, you may find that the genes for cytochrome proteins varies across different individuals. That's why you end up having what we call the rapid metabolizers, slow metabolizers, intermediate metabolizers. So you give the same medicine, but the patient takes the body processes the medicine differently because of the difference in the genes that the individual carries. So that's what we call polymorphism. So there's also a thinking that and this other, like a T-helper 1 response signaling pathway, which involves the tumor necrosis factor alpha and interferon gamma, it is associated with polymorphism, like different individuals have different genes, but doing actually the same thing. So because of that, a particular group is at risk of developing lichen planus because of their genetic makeup. This also extends to the cytokines and also extends to other genes that are related to oxidative stress and thyroid hormone synthesis and also inflammatory mediators. So that is the linking that we have now currently with for lichen planus and then the genetic aspect of the individual. So when you go to the environmental factors in lichen planus, we've seen that sometimes there's a strong association of lichen planus with infections like hepatitis C viral infection. And this is because lichen planus is like 13 times more common in patients with hepatitis B infection. That's where the link comes from. So you'll see that patients with lichen planus, most of a great deal of them can be having hepatitis C infection. So that's where the relationship comes in from. And this correlation is also seen usually in the Mediterranean people in Germany, Japan, and USA. And there's also a possibility of immune response dysregulation, maybe in response to hepatitis C, that ends up giving the presentation of lichen planus on the skin. And there's also actually something noticed that every time someone has lichen planus and then they are discovered to be hepatitis C positive, every time they treated the hepatitis C, hepatitis is one of the treatable viruses and it can be cured. So every time it was cured, even there was almost spontaneous resolution of lichen planus. So that's why there's this link between lichen planus and hepatitis C. So other viruses that have been linked to lichen planus include the human papilloma virus, the HPV virus, especially when it comes to oral lesions of lichen planus. It is seen that in patients with lichen planus tend to have a higher propensity of a human papilloma virus. Then other virus like the human herpes virus 7 and even 6 as well, hepatitis B, varicella, and Epstein-Barr virus have also been linked to lichen planus. Then furthermore, lichen planus has also been associated with vaccination. This is because lichen planus has been seen to either to appear or worsen after vaccination, especially if people get vaccination for hepatitis A and B, influenza, and then also the COVID vaccine. So that is why when you're taking your history in lichen planus, you have to ask about history of vaccination, either during, after, or before the onset of the clinical presentation. So that is usually very, very key because some vaccines have been actually associated with development of lichen planus. And at least you should remember these ones: hepatitis B, hepatitis A, influenza, and then the COVID vaccine. And of note, usually when they were giving out a vaccination for hepatitis B, there was a slight increase in the prevalence in the patients that we used to see presenting with lichen planus, and that is usually connects the dots that we are looking at here. So if you are to continue further, still in the environmental factors, we've seen that the microbiome dysregulation has also been linked to development of lichen planus, especially the altered microbiome in the saliva in the mouth has been associated with lichen planus. And then we've seen the significant changes in the bacterial, fungal, and viral populations that reside on the skin in patients with lichen planus. planus. So that is still a theory, not yet proved. And then other things like contact allergens, like the dental metals like mercury and gold that we use to coat the teeth, the dental people, they use those gold-plated dentures or gold, or sometimes they may have mercury and other heavy metals. It has been noted that those that use these heavy metals end up developing oral lichen planus. And other chemicals like the phenylene diamine and the methyl acrylic acid esters have also been to induce a lichenoid reaction. So that's now the association with contact allergies and versus development of lichen planus. And then particular drugs have been also been thought to induce lichen planus, like the beta blockers, antimalarials, and even some new biologicals. These are linked to development of lichenoid reactions, and because of that, they're also thought to play a role in development of lichen planus in a particular set of patients. Other physical factors like mechanical injury, maybe after surgery, after tattooing, and this is seen because even lichen planus shows what we call Koebner phenomenon. This one we discussed it earlier in the previous videos. And in Koebner phenomenon, we said that someone develops lesions along line of injury. So that simply shows you that mechanical injury or damage to the skin can induce or worsen lichen planus. Then other things like severe psychological stress, anxiety, depression can also trigger or worsen lichen planus. We also have metabolic factors like accumulation of succinate and the mTOR pathway upregulation has also been linked to development of lichen planus. So all these follow under what you call the environmental factors that contribute to the development of lichen planus. Then we have now the other arm, the third arm, the immunopathogenesis. And in this case, we see lichen planus to be one of the complex immunological disorder, which is primarily driven by the T cells. And this is, if you have to note, it is similar to psoriasis. But they have a difference in the pathways. So here, the key immune mechanisms that we see in lichen planus, we have the T lymphocytes, we have the T helper 1, T helper 17, and then the CD8 cells, and these are the core cells that play a role in initiation and maintenance of this condition. So the cytokine profile that we usually see, we have secretion of interferon gamma, which is by the T helper 1, and then interleukin 17 by the T helper 17, and these ones usually promote inflammation and keratinocyte apoptosis and also damage. So when you look at how does the disease start, we categorize it into two phases where we have initiation and then we have progression, which also comes with maintenance. So in initiation, there's a thinking that someone gets exposed to particular antigen that activates the dendritic cells. This is similar to what we see in psoriasis, but in psoriasis, the difference is you have in psoriasis, the difference is that you have an unknown trigger, which can either be an infection, which can either be RNA, DNA from a virus, maybe unknown antigen, but in that case, you are not sure what causes the activation of the dendritic cells. But now, here there's a thinking that you have antigen exposure that causes activation of the dendritic cells and the keratinocytes, leading to type 1 interferon production. That when it is produced now, it will now go and activate the T cells, promoting differentiation and then also clonal expansion. So after that, then you have what you call progression. So someone forms memory T cells that usually migrate to the lesions, and then they start producing pro-inflammatory cytokines, interferon gamma, tumor necrosis factor, and then interleukin 17. Then there's an increased adhesion molecules that usually facilitate and T cell infiltration and promotion of chronic inflammation. So if you are to look at now each particular cell and what it does, in this case, we are starting with the T cell lines. So in this case, if you start with this CD8, those are the cytotoxic T cells. Usually, they will come and mediate epidermal damage via the granulocyte exocytosis. They form perforins and grand enzyme B that damages the keratinocyte. So in this case, the difference, if it was psoriasis, in psoriasis, you have proliferation of keratinocytes, but they don't die. You don't have necrotic keratinocyte. But in lichen planus, once you have your antigen, so your antigen will cause activation of the dendritic cells and the keratinocytes. So when they are activated, they will produce particular inflammatory mediators and cytokines that will now go ahead and cause activation of the T cells. And now in the T cells, you'll activate the CD4, which are the T helper cells, and also the CD8, which are the cytotoxic T cells. So when you activate the cytotoxic T cells, they will now come back and damage the keratinocytes that are presenting or expressing that antigen. You understand? So that's now the major difference. In psoriasis, when you activate the cells, you'll only activate the T helpers, right? T helper 1, you activate T helper 17, and then T helper 22. That is in psoriasis. But and when they come, they just cause promotion of pro-inflammatory cytokines that end up producing more keratinocytes. That's why you end up with very thick plaques in psoriasis. But in lichen planus, the line of cells that is activated include the cytotoxic T cells. So they will come and then mediate damage via the granulocyte exocytosis and production of porphyrins and grand enzyme B that end up damaging the basal keratinocytes that express that particular antigen. So that is now the difference. So now, if you have to look at some papers, we're actually saying different pathways, where one is thought to be the antigen specific pathway. That's the one we've discussed. Then the other one is thought to be the mast cell activation pathway. So in the mast cell activation pathway, you'll have particular unknown triggers activating mast cells, resulting to production of particular proteins, including the matrix metalloproteases. So these enzymes, once they're produced, they will cause damage to the matrix, and this now will eventually results into easy penetration of cells, cytotoxic cells, that will come and damage the basal keratinocyte. So you have to take note of those differences. So if you have to proceed further here, the different cells that play a role in lichen planus, we have the mast cells. They are thought to release mediators that amplify the inflammation. We have regulatory T cells, the Tregs, that are defective in lichen planus, failing to control the effector cell response. So you know that every time you trigger an immune response, you have now to counteract to prevent further damage to the tissues once you have maybe eliminated the antigen. But now there's a thinking that the regulatory T cells in lichen planus are not functioning, so they are defective, so they are not able to control the triggered response. Then we also have the tissue-resident memory T cells that usually contribute to disease reactivation. When you go to the cytokines and chemokine network, we see that in lichen planus, you'll have elevated levels of particular chemokines, including the CXCL9, then CCL5, and then also the matrix metalloproteases, the ones I've mentioned earlier. And these promote inflammation and cell migration that end up disrupting the basement membrane. And that's why lichen planus is one of the conditions that we say it gives an interface kind of picture, even on histology. And then the other factor that contributes is what we call oxidative stress, which usually gives an imbalance between the pro-oxidants and then the antioxidants. And because of this imbalance, the pro-oxidants increase, and then these ones also play a role in progression, initiation, and maintenance of lichen planus. So when you go to the dendritic cells, these are, they are the guards of the epidermis and the dermis. They are supposed to identify particular antigens and then present the antigen and trigger T cell activation to eliminate that particular antigen, which can either be an infection or it can be an autoantibody or an autoantigen that the body needs to get rid of. So they also play a role in antigen presentation as well as the T cell activation and propagation of the disease. So we have different subtypes of these dendritic cells. We have the Langerhans cells, the CD1A plus positive cells. These are found in the epidermis and they produce interferon alpha. Then we have the myeloid dendritic cells. These ones activate the T cells and produce interleukin 12. And then we have the plasmacytoid dendritic cells. These ones usually they're the main source of interferon alpha, and they drive the type 1 immune response. So we also have macrophages playing a role in lichen planus, and they are thought to, because when you examine the lesional skin, there will be in increased numbers, and usually the ones that dominate are the M1 type of macrophages. You have two, M1 and M2. In this case of lichen planus, M1 is the one which dominates, and the function is antigen presentation. They also secrete pro-inflammatory cytokines that also help to drive the inflammatory process. Then you have the lymphocytes, which is predominantly the CD4 positive cells and then the cytotoxic cells at the dermo-epidermal borders. And we know that the CD8, they are the cytotoxic cells, are the ones that destroy the keratinocytes. And then the CD4, they are helper cells. They are the ones that are responsible to activate the cytotoxic T cells. And also, they also secrete pro-inflammatory cytokines. So this pathogenesis may be a little bit confusing because it has now a lot of interplay between the particular cell lines in the skin. So you have to take it slow and then understand that you have three arms. The first arm being genetic component, the second arm being environmental triggers, and then the last arm being the immune system of the person. So those three arms play together, interplay to give rise to lichen planus. So we have more cells. The natural killer cells have also been shown to increase in lesional skin, and these ones also may help to activate more T cells. Then we have keratinocytes, which are usually the target for apoptosis in lichen planus, and they present the antigen. And then we also have mast cells. I've mentioned mast cells. They produce for you those MMPs and also all those other pro-inflammatory mediators like interleukin 16, tumor necrosis factor, and the rest. And then you have neutrophils. There's limited data for neutrophils, and most of the times they are just a little few scattered neutrophils, but most times not present in lesional skin. So if you are to go one chemokine or one cytokine by one to see the major roles that they do, this is how you could write about it. So it's starting with the interferon, interferon gamma. So this is one of the most important cytokine in the prognosis, also in the progression and initiation of lichen planus. So it is increased in lesional skin and in saliva for patients who also have all lichen planus, and it stimulates major histocompatibility class 2 expression on keratinocytes and T cell migration. It also activates the JAK-STAT pathway, and this correlates with the disease severity. So we know that after you having your antigen, if the keratinocyte is having the expression of the antigen, so you need mediators that will take this information, right? So now the chemicals that are produced like interferon alpha plays a very important role because one, it would stimulate the expression of major histocompatibility class 2. And you know that when you present class 2, it simply means you are presenting an antigen, isn't it? At the cell surface. So if it is class 2, this antigen will be picked or this information will be processed by the CD4 cells. So after the CD4 cells have picked up this information, they will now migrate and take this information to the nearby lymph node or lymphatic channel where we have the naive T cells. Now the T cells that are naive will now be forced to undergo colon expansion. Then they'll come when they're specific, looking for that particular antigen that is expressed by the keratinocyte, and that's where you're having the interferon alpha playing a role. And then the tumor necrosis factor, this is produced by the T lymphocytes, the natural killer cells, and the dendritic cells, as well as the keratinocyte, and it is elevated in lesional skin. It promotes inflammation and chronicity of the condition. So it also correlates with the activation of a tumor nuclear factor kappa beta, and the net effect is promoting stimulation of inflammatory mediators. Then in the interleukin 12, this is secreted primarily by the dendritic cells, and it enhances the production of interferon alpha and interleukin 2 production, which is crucial for T cell activation. Then interleukin 23, this is produced by the dendritic cells and macrophages, and it plays a role to activate the T helper cell 17, leading to which also eventually will produce for you the interleukin 17 and interleukin 22 production. We know interleukin 17 and 22, they promote inflammation in the area. So interleukin 17, once it is there, it will elevate. It will stimulate more of the damage of the keratinocyte and promote more inflammation. And it also thought to stimulate T cell activation as well as extracellular matrix damage. Then interleukin 21 also promotes cell differentiation for the T cells and the natural killer cells, and we see it increased in lesional skin in lichen planus. Then interleukin 6 is associated with formation of new blood vessels. It's also elevated in lesional skin, and interleukin 18 also works together with interleukin 12 to enhance the cytotoxicity that we see in this condition. So that is the pathogenesis. I know it's a little bit tricky, but that's the current update that we have. And there are so many cells that are now thought to be involved in lichen planus, initiation, progression, and maintenance. And there are so many cytokines. But take it slow, take it step by step, and then maybe you get one picture at a time. So looking at now the differentials, the variants of lichen planus, starting with the oral involvement. You know, lichen planus loves the mouth as well. Oral involvement or lichen planus has a lot of variants as well, which are just morphological variants. So their variants are described depending on how they look like. The first one is the reticular variant, which usually has the typical Wickham striae, as you can see in the picture, that whitish coating there, that is your Wickham striae. And the next one is what we call erosive. In this case, you'll have an erosion or an ulcer, which is usually very painful with pseudomembranes. And oftentimes it is irritated by dental products and even foods. So you have like a wound. And the erosive type is one that is usually associated with the development of squamous cell carcinoma in the mouth. So every time you see it, you have to treat it aggressively. Then you have the atrophic type. In this case, you have thin mucosa with a red and smooth appearance, which may also be painful. That's the atrophic type. Then you can have a plaque-like type. In this case, you have white thickened patches, which resemble leukoplakia and can be also mistaken for oral ulcers. Then you can also get blast type, or you form vesicles and blisters in the mouth that can either rupture, leading to development of ulcerations or even erosions. That's a blast type. Then you can also have the papilla type. In this case, you'll have very tiny, small papules on the buccal mucosa that will also be lichenoid. So in the all lichen planus, you can have these morphological variants: reticular, erosive, atrophic, plaque-like, bullous, and papilla. Then lichen planus also involves the nails. So in this case, it will affect up to 10% of patients with disseminated lichen planus and can be the sole manifestation of lichen planus. Oftentimes seen in the 5th and 6th decades of life, and it affects both genders. equally. So the features that you usually see, you can see longitudinal ridges. You can also see pitting, just like in nail involvement in psoriasis. You can see onychorasis, which is, they are just brittle nails that easily break. As you can see in this picture here, these nails are not growing, they are easily breaking. They have these longitudinal ridges, and then they have this violaceous hue. And then you can also get the distal splitting. You can get brown discoloration, as you can see here, the discoloration. Then you can also get rough nails with what we call tracheonychia. And then you can also get onycholysis, where you have the separation of the nail plate from the nail bed. So when you have like 20 nail dystrophy, where you have a patient presenting with all the nails having a disorder, you have to think about lichen planus as one of the things that can give you that picture. So the next one is linear lichen planus, and the linear lichen planus, as the word says, line. So this is a rare variant of lichen planus, and it affects only 1% of all patients with lichen planus. And up to 10% of the Japanese patients with lichen planus may present with the linear form, and there's no significant gender predilection. So most of the times, linear just means a line. You can get this via, if there's a combinalization, someone gets an injury and then they get lesions developing along this line, just as you can see in that picture. So that will be your linear lichen planus. So still, someone will have the classic papules of lichen planus, but just arrange it in a linear pattern. Sometimes can even follow brush code lines, and typically it is usually unilateral, pruritic, but can occur on any body part. And the involvement, you just see the classic lesions of lichen planus with the 6 P's that we mentioned first, but now in this case occurring on a particular line. Then we can also have what we call the annular lichen planus. Now, in annular lichen planus, and someone has this is also another morphological variant, contributing about 2 to 7% of all the cases, more common in men than women. And still in the clinical picture, someone will have this red-purple circular macules and plaques with raised borders, and they can either have one lesion or multiple, ranging in about 1 to 8 centimeters in diameter, and commonly loves the intertracheinous areas like the axilla and the groin, but can also occur on the lips, trunk, and the arms. Even genital lesions can also tend to pick up this morphological variant, especially the ones that involves the penis, scrotum, and you see sometimes you can also get atrophic annular lichen planus, whereby the center becomes now atrophic, and sometimes it can also be asymptomatic. So as you can see in this picture, if I may magnify, as you can see in this picture here, so this is now annular lichen planus. You see these annular plaques with a raised border with some sort of central atrophy. So that is the variant of annular lichen planus. Then there's what we call atrophic lichen planus. So in this case, it's also a little bit rare, and it usually affects areas where you have a previous lichen planus lesion. So maybe the first lesion there was annular or any hypertrophic lichen planus, but then as it heals, it leaves it comes with a skin atrophy, so it will now become the atrophic lichen planus. So you'll get a well-demarcated whitish, white bluish or brown papule or plaque, and in this case, it typically occurs after either someone has had annular or erosive lesions of lichen planus, then the remaining area becomes atrophic. So it can be on the axilla, the glans, penis, the lower extremities, or the trunk, and that's how it will look like. As you can see in this picture, you see this area of central atrophy, which is just below the normal level of the skin, and that is what we call the atrophic lichen planus. Then we have what we call hypertrophic lichen planus, and hypertrophic lichen planus is just usually seen on the lower limbs actually, or the upper limbs, but in this case you have hypertrophic, very thick papules and plaques, and we see that there's also an association of hypertrophic lichen planus with squamous cell carcinoma. So even in a particular study done in 2005 showed up to 10 cases of squamous cell carcinomas developing in hypertrophic lichen planus. So you should also note that when you see a patient with hypertrophic lichen planus, you need to follow them up and screen them for possibility of developing squamous cell carcinoma. So that is how it will appear like. As you can see, these are very, 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 very thick plaques on the lower limbs, and that is hypertrophic lichen planus. And you can see this whitish coating, and when you do your dermoscopy, you will see there becomes striae. Then we have inverse lichen planus. Inverse lichen planus affects the intertrogenous areas that includes the axilla, the groin, the gluteal cleft, the limb flexures, and then also the submammary region. So in this case, you'll see the typical morphology, but now it will be just the location that will give you this diagnosis of inverse lichen planus. But oftentimes it can be hard to diagnose it, especially if someone is very sweaty. The macerative effect of the sweat can alter the initial presentation of the lesion. So, but you have to be careful if you're looking at intergenous areas, because even other conditions like psoriasis, septum, and atopic dermatitis can tend to be living these areas as well. So you have to make sure you delineate between those conditions. Then we have what we call eruptive lichen planus. Now, in eruptive lichen planus, it's also called exanthematous lichen planus. In this case, someone will develop a generalized picture of these polygonal violaceous papules and plaques that are usually very, very itchy. So it can affect the entire body, trunk, face, the limbs occurring all at once. So that's what it is like. It can even be tending towards even erythroderma. You can end up with being erythrodermic. So someone will have erythematous flat-topped polygonal papules and macules, and sometimes they can even be umbilicated. They will be violaceous in color, that is the purple, and they are commonly seen on the trunk and all the forelimbs, plus the mucosal surface. So in this case, you may need to give medicine aggressively because it is and systemic treatment because of its distribution that covers almost the entire body. Then you can also get blast lichen planus, whereby you have now vesicles or bully on lesions of lichen planus. And when you look at a literature review, the prevalence of this is a little bit difficult to estimate, but most commonly seen in young patients. And when you see this, it is usually it is a little bit more severe, and even the duration it takes it's a little bit longer compared to the other types of lichen planus. And there's a possibility that it may be autosomal dominant, and it will be part of the familial type of lichen planus with variable penetrance. That's according to some article by Haig in 2017. And then the clinical presentation, someone will have this dense bullae, and then the typical violaceous or purple color and polygonal lichen planus lesions all over the body. Commonly, it will be located on the dorsal aspects of the hands and feet, the trunk, and most frequently, it affects the legs as well. The differentials, you have to distinguish it from lichen planus pemphigoides, which is also another blistering condition that has a lichenoid picture. We have an overlap between pemphigoid, blast pemphigoid, and lichen planus. So it becomes lichen planus pemphigoides. So you should also distinguish it from other blistering condition. You can see you can have bullous SLE overlapping lichen planus. So you have to tell a difference between which is which. Then you can also have lichen planus pigmentosus. So in this case, it usually affects females in about age between 30 to 50 years. Middle-aged Indians are most affected, and commonly seen in people with a fused skin type 4, 5, and 6. And the clinical presentation, someone will have dark hyperpigmented papules and macules, oftentimes asymptomatic or a little bit itchy, seen on the sun-exposed areas, the scalp, the face, the neck, and the upper extremities are commonly affected, and you have to distinguish it from the erythema impastans, which usually starts in the neck here, and the fractures, and the post-inflammatory hyperpigmentation, or even the figure-8 erythemas. As you can see here, this hyperpigmentation that we see here, so that is your lichen planus pigmentosus. So it is one of the facial dyschromias that we usually see. Facial dyschromias are one of the hard things in dermatology to diagnose and reach a conclusion. Then we also have lichen planopilaris. So in this case, this is your lichen planus affecting the hair follicles. So it is a variant of lichen planus involving the hair follicles, primarily affects Caucasians and then also Indians, but has also been seen in people of African descent. And it is still poorly understood, but still related to T lymphocyte-mediated inflammatory response, which targets particular antigens within the hair follicles. So in the clinical picture, you will see whitish atrophic patches on the scalp that may include hair shedding, itching, and then also tenderness. Sometimes someone will present with the classic lichen planus pigmentosus, or sometimes they can present with frontal fibrosing alopecia, or even the Graham-Little-Picard-Lesser syndrome. So in Graham-Little-Picard-Lesser syndrome, you have a couple of things. So you have papules on the skin that are lichenoid. Then you have a scalp involvement, and in scalp involvement, you have the lichen planopilaris as the feature. Then in the differentials, you have to think about all the other causes of scarring alopecias, including the discoid lupus erythematosus, and then even seborrheic dermatitis. So this is how it will look like. So as you can see, this the lichenoid papules with hair loss affecting the hair follicles. So someone ends up with a permanent alopecia. So we can also get the vulvovaginal lichen planus, and in this case, it will affect the vulva and the vagina predominantly, seen in premenopausal Caucasian women, most of whom are above the age of 50. And in the clinical presentations, you'll get genital ulceration with itching, burning, and all this purulent discharge in the genitalia. And in physical examination, you see this inflamed erythematous or eroded epithelium with the Wickham striae, or with this reticulated white-gray lacy pattern that we see even on the oral mucosa. So the differentials there down will be the lichen sclerosus, or the autoimmune vesiculoblast diseases that usually also involve the mucosa, like the bullous pemphigus and the squamative inflammatory vaginitis. So the other one is the actinic lichen planus, and this is also part of lichen planus, but it's a bit rare, affecting sun-exposed areas, more common in the dark-skinned individuals, and the eruption may predominantly occur in the spring and summer. And in the clinical picture, someone will have the annular or pigmented, or even dyschromic picture. Oftentimes it's asymptomatic. So commonly it can affect the face, the chest, and the hands. As you can see in this picture, this is what you have as actinic lichen planus, and you see the skin color of this individual. You see it is also affecting the oral or the lips, having that violaceous hue, as you can see there, these lips here. And then you have all this violaceous pigmentation with all these lesions in the neck. Then we can have lichen planus overlapping with lupus erythematosus. So in this case, it's a little bit rare, but it has been reported in about 50 cases. And In the presentation, you'll have picture of lichen planus and also a picture of lupus, or both. So in this case, it can affect the arms, the legs, the face, the trunk, and then also the palmoplantar surfaces. And in histology, you can only tell a difference between the two. You have to do direct immunofluorescence that will reveal the features of both diseases, and then you'll have granular deposits of immunoglobulins in this picture. So in this picture, when you take off even histology, you'll have a confused picture having both features of lichen planus and then the lupus erythematosus. Then lichen planus pemphigoides, now this is a little bit different from the bullous lichen planus. So lichen planus pemphigoides is a little bit also rare, and it's an autoimmune blistering condition which shows features of both lichen planus and then the bullous pemphigoid with a male predominancy, commonly affecting individuals in their 40 to 50 years. Commonly, you have in etiology, you have autoimmune response and dysregulation to the desmosomal proteins or the keratinocytes derived antigen that now trigger the reaction, and then we end up with the keratinocyte apoptosis and then forming of these blisters or blistering. So in the clinical picture, someone will get tense blisters, as we see in the bullous pemphigoid, that can involve both the involved or the uninvolved skin, oftentimes the extremities, and then also oral mucosa. So remember, in the bullous lichen planus, the bullous is located within the lesion of lichen planus. But now in lichen planus pemphigoides, the bullous lesion can be both where you have the lesion and then also on the skin that does not have the lichen planus-like lesion. So that is now the difference on clinical. So even when you do histology here in lichen planus pemphigoides, you will see features for both lichen planus and then the bullous pemphigoid. Or even when you do direct immunofluorescence, it will give you a specific deposition pattern. So now this table tries to summarize everything. So what you will do for me, you'll pause the video, then you look through all of them. And this is what we've been discussing. There are common clinical aspects and then the site and the population that are commonly affected when it comes to these variants of lichen planus. So we have actinic lichen planus, acute erythematous lichen planus, also called eruptive, annular. You can have atrophic bullous, hypertrophic, inverse, lichen planus pemphigoides, lichen planus pigmentosus, lichen planus piranopiralis, linear lichen planus, lichen planus early overlap, nail lichen planus, and all these are the different pictures. So when you go to histology, how does lichen planus appear? So lichen planus, when you take off a sample for histology or H&E staining, it will give you a classic lichenoid dermatitis. You know, when you say interface dermatitis is usually divided into two: the lichenoid arm and then the vacuolar arm. So the typical lichenoid arm is where you'll have the lichen planus, and you have to remember this. So in this case, for lichen planus, even the histology books, they will tell you that lichen planus on histology is like a strict parent. It doesn't allow parakeratosis, and it also doesn't have eosinophils. Then you get an interface picture, but without parakeratosis and without eosinophils. So when you see that, then you can comfortably make a diagnosis of lichen planus. So other features that we usually see include hyperkeratosis, acanthosis. You can get the thought-toothed red ridges. You can get lymphocytic infiltrate, and then you can get the civet, what we call the civet bodies. I'm going to show you these ones, and then the basal cell squamatization or flattening of the basal cells. Then parakeratosis is generally absent. So every time you see it, you think twice before you make a diagnosis of lichen planus. Then you can get melanin pigment incontinence and other features. So as you can see here, for example, in this histology slide, so this is the stratum cornea from here up to there. Then this is what we call the civet bodies. You see these ones? These are what we call the civet bodies. And you have this interface dermatitis. You see interface because you're destroying the basement membrane, the basal cells, that you don't have a clear picture along the dermal, epidermal junction. And you see this infiltrate of lymphocytes that are everywhere. And then you see this dead keratinocyte, like that one is a keratinocyte that is dying. Even that one is a keratinocyte that is dying. So you see necrotic keratinocytes together with these other features. So, and then here you can see the sawtooth red ridges. You see that? You see that sharp border? So that is now what we call the sawtoothed red ridges. I think when I do that, you can see now the pattern. This looks like a saw. You know that saw, that the chainsaw that they use to cut something. So that is how it will look like. You see that that's how the picture is, the sawtooth red ridges. Then this is also another picture. Still, it is showing you the same features: sawtooth red ridges, the lymphocytic infiltrate, destruction of the basement membrane, and that arrangement of the basal keratinocytes being interfered with. So that is what we see in lichen planus. So what are the treatment options when it comes to lichen planus? So the treatment options are valid, and we want to classify them depending on the case. If it is mild to moderate cases, you can do only the topical. In this case, you can do high potent corticosteroids like probetasol, which is applied maybe twice a day, and someone will get improvement. Or you can add topical calcineurin inhibitors like tacrolimus or pimecrolimus, or you also can add antihistamine for the itch that comes with lichen planus. So in case you have resistant or widespread disease, you can do intralesional steroids like triamcinolone. Then you can also go for systemic treatments like oral prednisolone that you later taperon. And then you can also do oral retinoids like acitretin, isotretinoin, in case you have mucosal involvement. So in severe refractory cases or chronic cases, you can give immunosuppressors like cyclosporin, methotrexate, and then also hydroxychloroquine. Then phototherapy is usually very important. If it is available, we can do narrowband UVB in case you have generalized involvement, and especially in patients who have other comorbidities, diabetic, and you don't want to give other medicines that may alter the other medicines they are on, or that can cause drug-to-drug interaction. You can run through phototherapy. Then other adjuvant therapies or supportive therapies that have been seen in some case reports include antibiotics like glucophulvin, metronidazole have been used in some cases to improve lichen planus. Then topical agents like anesthetics in case you have painful oral mucosa lesions like in erosive lichen planus of the oral mucosa, you can give like topical lidocaine. This is usually available in things like BBC sprays that someone sprays in the mouth to at least to give some relief for them to allow them to eat. Then you can also do skin grafting in case you have ulcerative lesions that are resistant to treatment. You take it out, replace it with other skin. Then the prognosis, we know that lichen planus is one of the chronic conditions that can sometimes be relapsing. But if someone has only cutaneous involvement, usually in 1 to 2 years, some literature says 3, the lesions will be able to disappear. If it is oral involvement, it takes a little bit longer time. That can go even up to 5 years, or sometimes even up to 10 years. But most of the lichen planus, it will clear within 10 years. Then other associated complications like scarring, even remissions have been also reported. Then also, as because of if you get lichen planopilaris zone that affects the scalp hair, you can end up with this cicatricial alopecia. Sometimes if it affects the nails and it is very extensive, you can end up with dystrophic nails. So cancer risk, we said that or lichen planus, especially the erosive type, has been associated with squamous cell carcinoma, and the risk is about 0.4 to 5% over the next 5 to 20 years. And even the vulvovaginal lichen planus can also predispose someone to developing squamous cell carcinoma of the vulva. Thank you for watching. I know it has been a long one, but we encourage you to subscribe, share, and tell us what you want to learn more, so that in the next video, we prepare something specifically for you.